All right, you should be able to see my screen with the title page. Allison or Tanya, can you confirm that you can see that?
Yes, we can see it.
All right, perfect. Well, we'll get going. So this was the last time I spoke for the Myasthenia Gravis Association, and this was actually the Foundation of America conference that was in Kansas City in 2018, and it was a very well-attended conference with many national experts, and I also very much appreciated the invite to be able to speak at this conference. But today we're going to focus on surgery as one of the treatment options for patients who have myasthenia gravis. And this is a bit of an outline. And before I start, I just want to say that I would prefer if everybody who's in attendance turn in their questions as they are thinking about them and not necessarily save them to the end. I think this makes for a much more interesting format where we can share information as we go along rather than just waiting till the end. So please don't be afraid to interrupt me and ask questions, and I will stop in the middle and we can chat back and forth so that we can make this really beneficial for you guys. So here's the outline for today's presentation. We are going to define what the thymus gland is, and we are going to talk about what does it really mean to do a thymectomy and how a thymectomy might be performed, and what are the benefits of a thymectomy, and also what are the expectations after this procedure. So we're going to start by defining the thymus gland, and the thymus gland is not very well known outside of the circles that that we run into. It is actually a smallish gland that is located just beneath the breastbone and basically in between the breastbone and the heart. And it's interesting because it reduces in size throughout childhood, and at its early stage when the baby is not born yet and really for the first year or two, it is a generator of immune system cells called T lymphocytes, and that's why they're called T lymphocytes, because they come from the thymus gland. After the age of 3 to 5, after toddler age, the generation of T lymphocytes or T white blood cells changes gradually to the bone marrow, and that's where the white blood cells are all made in adults. And then this thymus gland basically stops being active and turns to essentially fatty tissue. And when we do heart surgery on patients and we open the sternum, we always see that. And since we, at least since I only do heart surgery on adults, whenever we see the thymus gland, it's basically changed completely to a fatty tissue, and it's usually pretty small, maybe the size of a golf ball cut in half or so. In children, it's a much larger organ. That's probably twice the size, and it's very meaty looking and very active and cellular. And if you were to open up somebody's chest, this is a cartoon, but it shows you number 7 is the heart, the pericardium, which is the sac that the heart sits in, and number 1 is the thymus gland, and it's a structure that looks a little bit like a butterfly. It has 2 lobes, 1 on each side, and it really goes all the way up into the base of the neck, so right where you feel that little notch at the bottom of your neck here. Number 2 is the windpipe, and then again, number 1 is that thymus gland. I know that outside of medical circles, probably not too many people know about this man, but he is the reason that we have discovered thymectomy is a treatment option for myasthenia patients. This is Dr. Alfred Blaylock, and he is a surgeon who is best known for inventing what's called the blue baby operation at Johns Hopkins in the 50s and 60s with another cardiologist by the name of Helen Taussig. And you might have heard his name before as part of that effort, and if you haven't watched the movie, there's a movie called Something the Lord Made, which shows the development of this procedure which granted has nothing to do with myasthenia gravis, but it's a wonderful movie of huge historical perspective and importance to the field of thoracic surgery, and more importantly, congenital or pediatric cardiovascular surgery. So at some point, Dr. Blaylock discovered that removing the thymus gland in patients who had a mass or a growth there also translated into improving their myasthenia symptoms. Myasthenia gravis has been treated for a long time, and mestinon, or the most commonly used medication to help treat symptoms, was actually first used earlier than that. And so it's not that we didn't know how to treat myasthenia symptoms, but this was really the first time that a surgical procedure was identified as helpful in treating this problem. And he published a series of 20 patients with improvement in at least 50% of the patients. Now, this is, pre-World War II, and all of these surgeries were done with a sternotomy, or opening the sternum, and that was the beginning of this movement. And it stayed stagnant for a long time. It didn't really evolve, mostly because technical advances didn't really develop until the 70s and 80s, when camera surgery began, and when also heart surgery became much more common and much more safe. Still in the 30s and 40s, having any surgery on your chest was an awfully risky procedure, and you really only wanted to do it if there was no other option. And so we certainly have come a long way since then. And when we do a thymectomy now, as I'll go over in a few minutes, the outlook, the risk, and the post-operative expectations are much different than what they were in the late 30s and early 40s.
Dr. Daon,
yes,
we have one question that's popped up, and I'm
Sure.
not sure if now is the time to ask it, or
anytime is fine.
or later on, with what you've already said. How long can a thymoma exist before it's detected or symptoms appear?
So that's a good question. A thymoma, which is a growth inside the thymus gland, can be either very slow growing. In other words, it might take years and years for it to become detectable, or it may be very fast growing if it's a more aggressive form of the thymoma. And this sort of growth is, in some ways, it's not really cancer, but if you will, it behaves like cancer cells in the sense that it is locally aggressive. In other words, it invades some of the organs next to the thymus gland, but it doesn't tend to send metastases or little seeds elsewhere in the body like breast cancer does, or colon cancer, or some of the other types of cancers. And so that's a good question. And when we find somebody who has a thymoma, most of the time it is discovered because that person had a CAT scan or CT scan for another reason. And so a few people can have symptoms if the thymoma gets very large, and those symptoms include shortness of air, or maybe hoarseness, or difficulty breathing with stridor, which is kind of a high-pitched noise when somebody tries to breathe because of compression of the windpipe. So that was a very good question.
And then one other question. Do you recommend a thymectomy for all MG patients?
So this we'll get to in
Okay.
a little while later in the talk.
Thank you.
And that's a very good question too. What's a thymectomy? Well, a thymectomy is a removal of the thymus gland, and of the whole gland, not just partially. It includes portions of it that are in the thorax and in the neck, and it also includes some of the fat that's around it, and it really is from one side of the midline to the other. The phrenic nerve is the nerve that makes the diaphragm move up and down, and that is the limit of the resection or the surgery when we do this procedure. And we remove the thymus gland from the very bottom near the diaphragm to all the way up in the base of the neck, and those are called the thymic poles. As I showed earlier, it kind of looks like a butterfly with the little superior poles here on the right side and the left side. The approach to this was standardized in 2002 when really the majority of thymectomy surgeries were done with a sternotomy procedure. In other words, you had to open the breastbone to be able to do this and get to all those little nooks and crannies and spaces to get the whole entire gland out. Things are different now. Nowadays, there are a variety of ways to remove the thymus where either all of it or almost all of it could be removed. Transsternal is what I just described, but also sometimes if the thymus gland is positioned a little bit higher in the chest and in the neck, a cervical incision or an incision just at the base of the neck could be used. We can use what's called video-assisted thoracoscopy, which is analogous to laparoscopy, except it's in the chest. And then robotic thymectomy, which is what most people are using nowadays, including me. And the reason for that is that it's a more advanced technology related procedure where we can do much more precise work inside the chest as opposed to all of these other techniques, and it avoids opening the sternum. So minimally invasive surgery is what we call surgery when we don't have to open the patient with a bigger incision. And this company called Intuitive Surgical has developed a surgical robot, which is shown here on the picture, where the surgeon is actually sitting away from the patient at a console that looks much like a video game console with little joysticks that are controlled by the hands, and then a viewfinder where we can see what's inside the patient. And in the patient, there's a camera and multiple instruments that can be exchanged, and all of these are put in through incisions that are about maybe a ½ an inch in length at the most. The really large and incredible advance that the robot, the Da Vinci robot that is made by Intuitive, provides us is it has a binocular camera so that when we're looking inside the chest, we're actually seeing inside in 3 dimensions. And one of the drawbacks of this system is that there is no tactile feedback, or we cannot feel the tissue like we could in open surgery. And so in order to know exactly how to move and what to do inside, this 3-dimensional image is far superior to traditional laparoscopy, where we just have a 2-dimensional picture on a screen. And then we have to kind of estimate the distance or the depth, as well as the resistance of the tissue, since we can't feel them. So this is really something that that set the technology apart from what used to be done. The little instruments on the end of what I showed you earlier, these things are articulated just like our wrist, and they're different attachments. Some are scissors or a needle driver or forceps or a cautery, but it's modeled after the human wrist with the same degrees of freedom of the human wrist, and it is controlled by these little joysticks or finger adapters underneath that viewfinder. So the view is actually coupled to the hands, which is exactly the way that it is when we do an open surgery. This is what it looks like in real life. There's a camera port and either 2 additional ports or 3, depending on the procedure that is being done. And then this is a picture of me sitting at the console, which looks a little bit different than the one that you saw a few slides ago, because this is a more modern version of the machine. And you can see that I've got my fingers inside the little joysticks, and I'm looking in the console here to see what's inside the patient. And this is a picture of a thymus gland after it's been removed. So it's, these are centimeters, so you can kind of get a sense for what it normally would look like. This is a pretty normal looking thymus gland for somebody who's in, let's say, their mid-40s or 50s. Here's another view, and in this case, it's not dissected out the same way that the previous one was, but you can see there's a little whitish area here that's been cut in half, and that's a thymoma, or a mass that's been growing inside the thymus gland. And we'll just discuss the significance of that in a minute. So after surgery, we, of course, have concerns about how to make sure that we minimize complications or outcomes that we don't wish for. And so we do a lot of preventative things to try and get the best results that we can. In order to do surgery on the inside of somebody's chest, we typically use not only anesthesia medication to put people to sleep so they are not awake and so that they don't remember anything, or feel pain, but we also use muscle paralyzers. And because Myasthenia gravis is a condition that already makes the muscles weak because of a neuromuscular issue, we certainly don't want to aggravate that by giving additional neuromuscular blocker agents. And so for the most part, when we do this surgery, we don't give agents that paralyze the muscles, but we instead use a larger dose of anesthetic medicine that puts patients maybe deeper asleep, is the best way to put it. So that's one concern. The neuromuscular blockade is probably the most significant one in patients who have symptoms that are linked to their breathing, or maybe have a harder time breathing. And those are typically the sicker patients who've had some myasthenia crises and require more preparation before surgery. We're also concerned about infection because many of the patients are taking immunosuppressant drugs, and those drugs, as they're designed to suppress the immune system, also make it more likely that if an infection should occur, it would likely be more serious. We worry about nerve damage for the same reason that we worry about neuromuscular blockade. We do not want to damage the phrenic nerves because those are the nerves that help people breathe. And of course, we don't want to make that any worse than what it already might be. We are worried about recovery time, and we are worried about recurrence of a tumor or a thymoma if somebody has one. So those are really good questions to ask if you're going to see a surgeon in preparation for having a thymectomy operation.
Dr. Daon,
Sure.
one question that's come up, is it possible that the patient may show symptoms of MG before it's visible on imagery?
Absolutely. Actually, that's mostly the case. I think it is much more common for patients to show signs and symptoms of MG before any imaging is done. And so, although there are patients who have signs and symptoms of a mass in the chest first, the most common scenario that I see is patients who come and refer who either don't have a mass or they don't know if they have a mass or not. So we'll do the scan and take a look after, but definitely the symptoms typically are the first thing that shows up. Okay, that was a good question too. What do we expect after surgery? So of course, this is a major surgery. It's surgery inside a main body cavity, and you have to be asleep completely for it. The surgery altogether, counting the time that it takes to go to sleep and time to wake up, takes about 2 hours. And after the surgery is finished, the recovery portion is either done in the PACU, which is also called the recovery room, or the ICU if there are concerns about breathing or breathing ability. We typically will leave a chest tube inside the chest, and that's just a little silicone tube that is positioned during surgery and that is connected to a drainage system in case there's any extra fluid or any extra air from inside the chest. And typically the chest tube is removed the next day after surgery. It's a pretty simple bedside procedure that's not very complicated. Most patients stay in the hospital, roughly 2 or 3 days. It just kind of depends on how they feel and how they're able to manage their discomfort or pain, and also their mobility. But the average is 2 to 3 days. And then if we run into trouble with a myasthenia crisis, or if we're doing this on a, let's say, a semi-urgent basis, which sometimes can be the case, we will often use plasma exchange therapy, which is also called PLEX, or intravenous antibodies called immunoglobulin G. The healing after surgery is really not very long typically, and that's because there's no big incision. So I would say by about 2 to 3 weeks, most patients are completely healed and able to do just about any activity that they wish to do. I will also confess that the majority of patients who I see, I do see through the clinic. In other words, it's fairly rare that we see somebody who has been hospitalized and needs surgery right away. Probably 95% of the procedures that I do are for patients who I see in the clinic first, and we set them up, make sure that their symptoms are well controlled, because that defines how risky the procedure will be. And then we do the procedure and send them home after that. So in a nutshell, that is essentially what we look for before surgery, how we perform the surgery, and what to expect after the surgery. The benefit of a robotic thymectomy procedure is that because it is minimally invasive, there is less pain involved after the surgery is finished. And less pain means that people breathe better. Instead of having a big incision on their chest and their sternum cracked open, it's, and I don't like to use that word, but that's how people refer to it. So it's just much more painful to be able to breathe if you have a big cut on your chest as opposed to 3 little ones. And that leads to a shorter recovery period, but also it also leads to fewer complications. Like poor healing of the bone is a terrible problem, and we just don't ever see that with a robotic thymectomy. The biggest benefit to me is that we can do all this because of the robot and still perform an extended thymectomy, which is exactly the same as a thymectomy that would be done by opening the sternum. So now we're going to shift a little bit, and this will help answer the question that was posed earlier. What are the recommendations from the American Association of Neurologists? We know that there is an association between thymectomy and myasthenia gravis remission and improvement. We have known that since World War II. One of the things that was a little bit perplexing is that since World War II, there had really never been a large-scale trial or a study that was done to define exactly how much it helped to remove the thymus for patients who have myasthenia gravis. And so quite a few years ago, probably 20 to 25 years if I remember right, a randomized controlled trial was begun, and it was a worldwide trial that was originated actually by a neurologist that worked at KU for a long time. The trial separated patients with myasthenia gravis into 2 different groups. One group received prednisone, and the other group received surgery and prednisone. And because myasthenia gravis is not very common, it took a very long time for enough patients to be recruited into that trial. And it finally was published about 5 years ago. And much like we thought that it would, it showed improved outcomes over a 3-year period after the thymus gland was removed. This is a picture that shows the quantitative myasthenia gravis score over several months, up to 3 years, after somebody has been treated with either prednisone alone or thymectomy plus prednisone. The blue line is prednisone alone, and having a higher total score, quantitative myasthenia gravis score, is worse. That means you feel worse, you're admitted to the hospital more times, you have more events that are negative or bad. And then the red line is how patients did after they had a thymectomy procedure and prednisone. And you can see there's a significant difference between the two groups. This is a table that kind of goes through some of the events that have happened to these patients. And you can see, without spending too much time on it, they go from pretty severe, like life-threatening events, to maybe things that are not so bad, but still required hospitalization. And maybe is more immediate and can be seen as an investment, so to speak, compared to just taking a medication. So it's not that the surgery is benign and that we never see complications. We do, but overall, the message from this trial is that thymectomy surgery benefits patients who have myasthenia gravis as a whole. The study was really focused on patients who did not have a thymoma. So this is really very interesting because we're doing surgery on somebody who doesn't have a mass or a lump. We're doing surgery because we think it's going to help the patient's symptoms and reduce the patient's generation of these acetylcholine esterase blockers. So one of the fun things about this trial is, after it was published, people zeroed in on it and try to figure out, well, are there groups of patients in whom it's more helpful than others? And as it turns out, there's a few features that are different depending on the patient. And we found out that females are more likely to improve than males, so it's good to be female. It is also good if myasthenia symptoms began less than 5 years before the thymectomy procedure. And actually, the closer the onset of symptoms to the surgery, the more benefit the patients received. The thymectomy technique for the trial was a sternotomy, and so we believe that the robotic thymectomy is just as effective because the thymus gland is completely removed. I will also say one of the other things that stood out in the trial is that the more severe the symptoms, the more the patients seem to benefit from a thymectomy. This is kind of a slide that shows what we can expect in general as far as complications after a thymectomy procedure. There's a large difference between what surgery of the chest was like before the 1970s and after, as you can tell. The mortality for a robotic thymectomy nowadays is less than 1%, maybe half of 1%. And in most of the cases, it is certainly more frequent in patients who have repeated myasthenic crises and other medical conditions like previous heart attacks or strokes or things like that. Acute respiratory failure from a myasthenia crisis happens about 5 to 6% of the time. And again, it is much more likely to happen in patients who've had prior respiratory crises from myasthenia. And so in order to try and curb that, we will team up with our neurology colleagues at KU and admit the patient ahead of time and put them through plasma exchange therapy to minimize the chance of a crisis after surgery. So in a little bit of a summary slide, if you have a thymoma, we always recommend removing it because of the potential for cancer. And so that's really not a big dilemma of what to do. If there's no tumor or no thymoma, there are options. And it doesn't necessarily mean that you should have a thymectomy, but it is something that is to be considered if you would like the best chance of having symptomatic improvement. So the way I always put it to the patients is that, you know, if your myasthenia symptoms are not that bad, and you can live with it and you're not taking too much medication, then maybe you don't need surgery. Or on the other hand, if the surgery is going to be really risky because you have other medical conditions, then maybe that's not the best option. But in general, if somebody has myasthenia gravis, removing the thymus gland has been shown to help, and I would recommend it for that reason.
Dr. Daon,
Yes?
I know that thymoma is can be an issue, but another question that's in the chat box: can a thymoma spread infection to other organs?
No, it cannot. The only thing thymomas will do is they will grow near the thymus gland or locally and invade some of the tissues, you know, like the lungs or the heart, if it's particularly aggressive. So it doesn't spread infection or really have much to do with infection, but it does have to do with local invasiveness. And, you know, sometimes we do see patients who have an aggressive thymoma that we cannot remove completely. And, you know, of course, those patients don't do as well. They don't survive as long as folks who have a thymoma that's less aggressive. The success of this thymectomy operation is really more pronounced in patients with severe symptoms, patients who are female, and patients who have had onset of symptoms within 5 years. The surgery is very safe. Complication rate is extremely low nowadays, and one of the things that I really enjoy the most is the robotic technology has helped us lower this tremendously while continuing to give the benefit to the patient.
And Dr. Daon,
Sure.
is this considered an elective surgery? And do you know if Medicare pays for it?
So yes and yes. We really are very, very pleased with how this has turned out. And so we certainly wrote this spot down, and that's the way that most patients are treated who need a thymectomy now, is with the robot. But the question is this elective? It is. We never want to do this under duress or in emergency situation, because the risk of complications is higher. And Allison, can you remind me the second part of that question?
Sure. Does Medicare pay for it?
Yes. This is a procedure much like other cancer procedures, for example. I've never either seen or heard of Medicare or any other insurance company denying coverage for a thymectomy procedure.
Okay. And then is there any information about what can cause a thymoma in the first place, such as toxic substance exposure?
There is not. We actually do not know why certain patients develop a thymoma. It is clearly a cancer-like process, although, like I said, there's a range of aggressiveness to it. There is a staging system for thymoma tumors that grow, and the treatment for them, if it can be removed surgically, is to remove them. And depending on what the laboratory report says on the aggressiveness of the tissue, sometimes radiation is necessary afterwards.
Okay.
Does anybody have any other questions?
We have, it looks
Okay,
like
I'll
we
stop
have a
sharing my
tumor.
screen because that was the end of the slides.
Okay, it looks like if you have a tumor, would it affect your voice?
I'm sorry, can you repeat that? I had trouble hearing.
I'm sorry, it says if you have a tumor, would it affect your voice?
Typically, it would not. Tumors that will affect the voice I think if that were to happen, it would be a very advanced stage of thymoma. So that would be pretty unusual.
Okay. Thank you.
Do we have other questions? Other thoughts or comments? Looks like.
I think this is a very challenging medical condition. One of the things that is always very difficult to predict is how patients will respond to a thymectomy procedure in terms of benefit, because it's not the same for everybody. And one of the take-home messages that I always bring up during a clinic visit is that this operation is not like appendicitis, for example, where you go into the hospital for appendicitis, they take it out, and then you're cured. The cure is immediate, and then the patients get well and they never have any problems with their appendix again because it's out. This is a process, and just like it started as a process, it also can get better as a process. And so I always tell patients, you may see some improvement right away, but you may not. And if you don't, that's okay. Many patients see improvement over the next 3 to 5 years after a thymectomy procedure. So you will still need treatment. We don't expect that from one day to the next after the procedure, all of your symptoms will go away and you won't need any medication. This is something your neurologist will work with you over time. And, you know, the hope is that you can get off the medication that are difficult to take, like prednisone, for example.
Okay. Another question is, are you doing thymectomies for LRP4?
I'm sorry, can you repeat that again? I'm having a little trouble hearing. I apologize.
Oh, sorry. It says, are you doing thymectomies for the LRP4 patients?
Yes, I think the short answer is we do thymectomies for all patients that we can think we can help. And
Okay.
For the most part, you know, to be honest, most patients who come to have surgery don't really even know what their subtype is. And there's really been kind of some mixed data on that, but the good news is KU has a really strong neurology and neuromuscular department, so they can help define that, and we've worked together as a team for a long time now.
All right, let's see. Can myasthenia qualify as a disability due to its fluctuating symptoms?
Absolutely.
Okay.
And your neurologist is the person that will document that and be able to help you with that.
And then it looks like we have somebody's daughter has thymoma cancer and has tumors that continue to grow in spite of chemo and radiation, putting pressure on her lung. Do you know if this is common?
No, fortunately, it's not common, but it's a very difficult problem to solve if the thymoma is aggressive, as it sounds like it might be in this young lady. I think it behaves much like cancer and invades the surrounding tissues. And there's you know, there's certain organs that we just can't remove with surgery, like the heart, for example, or the lungs. And so the key is to try and catch that as early as possible. And you know, typically chemotherapy is not all that helpful, but you know, in somebody who's young, we want to throw the book at them and make sure we give them every chance that they can get.
Thank you.
Sure. Yeah, that's a very difficult problem for sure.
Do we have other questions? Dr. Daon, this has been so helpful.
Good.
I was diagnosed with myasthenia as a child, and so I had a thymectomy back in 1989, actually, where where they went in and broke all my ribs and took it out, and the recovery was, month or 6 weeks long. So it's really amazing to see how the process has evolved over the years.
Oh, it's been a real blessing, and I feel very fortunate to be able to be part of that team to to be able to help all these patients, because this is a tough problem. So I really appreciate you all inviting me to speak, and I'm always happy to take questions. And if if any one knows a patient who just wants to discuss this or talk about it, you can find me at KU Med's website, and I will certainly be more than happy to chat with you.
Awesome.
Thank
And
you.
any last questions before we sign off? I think that's it. Dr. Daon, thank you so much for oh, hold on, one more question. What if your neurologist is against a thymectomy?
So I have a couple of ways to deal with that, and it's not always easy. One way is to get an opinion from a different neurologist, and then to try and figure out what the right thing to do is. I think that also trying to find a surgeon who does this operation not as an occasional surgery, but somebody who does this regularly probably has more knowledge. We're very fortunate at KU to have an amazing faculty in the neurology department in their neuromuscular division, and is literally second to none. So I would always encourage patients to seek a second opinion if things sound funny, or if maybe they're not hearing what they want to hear.
Thank you. And it looks like a couple more questions popped up. Is there an age limit for that KU uses, or is it individualized?
Well, I'm not sure on which side of the age range we're talking about. Typically, we do not treat pediatric patients at KU. Typically, those patients are treated at Children's Mercy, which we are basically one program together for that. And then on the other end, the trial really didn't go into patients older than 65 years old, but some of it depends on the patient and the risk of surgery. So in some ways it does depend on the patient, but anybody of adult age or adult size would be considered.
Okay. And then I'm gonna butcher this because I'm terrible at reading medication names. Myocephalate and prednisone and mestinon. Following a flare-up, and I had the thymectomy 11 years ago. Is it likely medication will be lifelong?
It sounds like it probably will be, but like we discussed earlier, I think the flare-ups is fairly common, and so the doses of the medication may change. And I think after that long period of time, the more time passes, I think the more likely it is that you will stay on those medicines. That may be a better question for your neurologist to answer.
Thank you.
Sure.
All right. Any other questions? You guys, thank you for your patience as we tried Zoom webinar again this evening. I think it went a little better than Saturday. So we'll keep trying it out. But thank you, right. Dr. Daon.
Thank you so much.
Thank you for being with us this evening. And we look forward to our May virtual monthly meetup on May 17th. So,
perfect. Have a good evening, everyone.
Thank you so much. Bye.
Bye-bye.